is Jacqueline from Lichen Sclerosus Support Network, where our mission is to empower people with lichen sclerosus by providing evidence-based education and support so that we can live in a world where those with lichen sclerosus get diagnosed early, are informed, and educated. Now, if you find the information in our videos helpful, please consider donating your time or money so that we can continue our LS education and support efforts. Now, in today's video, we are joined by Dr. Margaret Cocks, and we are going to be talking all about penile lichen sclerosus. Yes, you heard that right. Many folks with vulvar lichen sclerosus may be surprised, but lichen sclerosus can actually and does affect the penis as well. And now we've been trying to do a video on this topic for ages, but trying to find a provider who is knowledgeable and treats people with penile lichen sclerosus and was willing to come on our channel proved tremendously difficult. So we are incredibly grateful that Dr. Cocks was willing to come on our channel and speak out on this condition. There is significantly less research on penile lichen sclerosus, less support and less awareness compared to vulvar lichen sclerosus. And so we're incredibly excited to launch this video today. Now, for folks who are unfamiliar with Dr. Margaret Cocks, she is both a dermatologist and dermatopathologist who specializes in the diagnosis and management of vulvar dermatoses, such as lichen sclerosus and lichen planus. She also sees patients for general dermatology for conditions like rosacea, acne, eczema, and skin cancer. And then her lab interests include the diagnosis of autoimmune blistering conditions as well as immunodermatology. Now, if you are a healthcare provider who specializes in the diagnosis and treatment of penile lichen sclerosus, or if you yourself have penile lichen sclerosus and you want to share your story, please consider coming on our channel. You can reach out to us. Our contact information will be in that description box below. And with that, be sure to like and subscribe to our channel so you don't miss out on any more lichen sclerosus content. Okay, so thank you, Dr. Cocks, so much for joining us and for being willing to be one of the first healthcare providers to speak on this topic, because you and I were chatting before, and getting healthcare providers to speak on this has been incredibly challenging. But we do know that lichen sclerosus can affect the penis, and there are many folks out there with penile lichen sclerosus who are looking for information, who reach out to us, and we are like, we're not really sure. So thank you so much for joining us today. Before we start, can you say a little bit about what you do? What kind of got you into this space of dermatology?
Sure. So I am a dermatologist at the University of Utah, and I have a special interest in vulvar dermatology. So I do a lot of vulvar lichen sclerosus in my vulvar dermatology clinic. But I'm also a general dermatologist, so I do all the kind of bread and butter dermatology like acne, eczema. And I also am a dermatologist at the VA, or the Veterans Affairs, where I see most of my male patients, because most of the patients there are males. And that's probably the place or the setting where I see the most penile lichen sclerosus in that population of male veterans. So that is kind of what I do. I also am a dermatopathologist, so I interpret skin biopsies. So that's a portion of my practice as well. I would say I'm probably about 70, 30, 80, 20 dermpath clinic. So I do more slides than I do clinic right now. But yeah, that's kind of where I am.
That must really come in handy, having that dermpath background when making some of these diagnoses.
Yeah, I mean, I'm a very big proponent of reviewing the biopsies that are done in my clinic and making sure the diagnosis is correct. Yeah, that has been invaluable. So I do really enjoy that part of my practice also.
Yeah, no, that's awesome. I did not know that you did that as well. But that's great. And for folks who are wondering, dermatopathology is basically someone that specializes in skin disease diagnosis through biopsies, right? Is that pretty much? Yeah.
Yeah. So basically, we're the doctors that look at the biopsy after it's been taken from the patient. So we interpret the diagnosis.
Yeah, perfect. So, okay, let's dive into penile lichen sclerosus. So, how does this typically present with patients?
Okay, so penile lichen sclerosus is a very interesting dermatologic disease, and it is, I think, overall fairly rare in terms of people who are presenting to a clinic for diagnosis because of symptoms. A lot of the times, penile LS will actually be completely asymptomatic, and many times is diagnosed after a circumcision specimen is sent for pathology, interestingly enough.
Hmm.
But if you are having symptoms of LS in the penis, some of the most uh, kind of prominent symptoms early on are going to be changes in the color of the penis, and usually the portion of the penis that is involved is the glans penis, so it's the head of the penis,
Hmm.
and the foreskin. So most often we think of penile lichen sclerosus occurring in people who have not been circumcised.
Right.
Um, and that has a lot of potential implication in the pathogenesis of penile LS. But for the purposes of presentation, what you're going to notice first is either redness or whiteness of that glans penis and the foreskin that's present there, and maybe the meatus, the urethral meatus, so the whole of the urethra that ends at the tip of the penis. In terms of symptoms that patients might be experiencing, some of the first symptoms are itching, and then pain with sex is really one of the main symptoms that patients also complain about when the disease is kind of early on. Later on, like vulvar LS, penile LS can lead to scarring, and there can be changes in penile function. So there may be sexual dysfunction, there may be changes in urination. So those are
Hmm.
symptoms that can kind of present later on as the disease has progressed.
Okay, got it. And so when you say scarring, um, we're talking about potentially scarring over that urethral opening
Yeah,
or scarring of the foreskin where it can kind of phymose and attach to the glands. Is that kind of what we're
exactly.
talking about?
Yeah, so
Okay.
phimosis is a real potential consequence of untreated lichen sclerosus. And essentially, what that means is you can't retract the foreskin down off the head of the penis. And with long term disease, you can have strictures of the head of the penis, and you can have wasting of the head of the penis because it's not really getting all the blood and nutrients that it would normally get if that tight band of the foreskin wasn't present. And you can also get changes to the urethra because
Mhm.
the meatus can be involved by lichen
Okay.
sclerosus. And what that presents as is thickening of that area with strictures as well. So again, you can have difficulty urinating ultimately because of that lichen sclerosus.
Yeah, that makes a lot of sense. I would assume too that the phimosis would contribute to the sexual pain if it's kind of stuck and can't retract, then any kind of sexual activity, whether it's, oral masturbation,
Exactly. I feel like
insertion, I would assume
anything.
that it's a tug, pull, and has potential to be incredibly painful. And there is that itch component too. So you mentioned that it's definitely not as common as
Yeah.
lichen sclerosus, but still present enough that you do see it in your practice as a
Yeah.
dermatologist.
Yeah.
So is it more common amongst certain age groups, do you think?
Yeah, that's a great question. When we think about vulvar lichen sclerosus, we think of it kind of the traditional teaching has always been as bimodal. So you're looking at
Right.
prepubertal girls and postmenopausal women, and a lot of that is kind of explained by the estrogen component. And in males, you obviously don't have that same um, hormonal milieu. So the thought when people have looked at this, I mean, some of the papers I looked at to see what the distribution is among the patient population found that there was no distribution. But I think in general, there more papers have shown that it's actually a triphasic distribution. At least that's kind of more of the recent ones where you see an increased incidence in boys or prepubertal boys. And then again, you see two peaks kind of at the end of the third decade, and then sort of later on at the end of the sixth decade.
Mhm.
And again, why that happens, I'm really not sure. I think in younger boys, I mean, we do it. The incidence there, from what I could tell, is the one paper I looked at was stating an incidence of about 1 in 200 in the pediatric population. while in the adult population, the percentages are so wildly variable that it's really hard to
Right.
pin a number on it. It is less than female. So one of the papers I looked at was saying it was somewhere between 0.0014% to 0.07%. But
Okay.
again, I don't even know how to visualize that number in my mind's eye.
Yeah.
But interestingly, and this is why when I started, I talked about like, is this predominantly asymptomatic in a lot of patients? The reason I say that is because there was one study that looked at circumcision specimens taken from patients in Australia. So these
Okay.
are patients of all comers who came in for a circumcision, regardless of whether they had LS or were being circumcised for some other reason. 67% of those specimens had lichen sclerosus on biopsy, which to me is like a mind-blowing statistic, suggesting
That
that the
is,
majority of these uncircumcised foreskin actually have lichen sclerosus. And how many of those patients were symptomatic? The paper didn't really go into that, but
mhm.
it may be more prevalent than we think, but patients are just not complaining of symptoms or having symptoms.
Right. And one thing that I find amongst people who have penises, and this might play into that whole asymptomatic, misdiagnosed, underdiagnosed piece, is that they talk to me and they're like, well, I don't even know who I would see
Right.
for a penile issue. Like, who even looks there? So if you don't have symptoms and there's no health care provider looking,
Yeah,
I mean, how many cases are just being completely missed? I mean, once upon a time,
totally.
too, we were saying that
Yeah.
vulvar lichen sclerosus is incredibly rare. And now we're kind of abandoning that and know that it's a lot more common than we used to think. And for the longest time, vulvar lichen sclerosus was being missed for a myriad of reasons.
Right.
So again, potentially it looks like it's rare, but it may actually be a lot more common, especially I think that biopsy paper really puts things
Yeah.
into perspective. And then again, if we think that if it often does present as asymptomatic, well, what would even get people into a healthcare provider's office if they're not experiencing symptoms? Typically, you don't go to your GP or your PCP for like an annual checkup. They typically don't look at the penis
Yeah. And I
unless
mean,
you
this
say
this
there's
day and age,
symptoms.
I'm always blown away by like the rudimentariness of the annual checkup. Like now you can
Right.
literally do these virtually. Like you don't even have to go into the clinic anymore.
Yeah.
Right. So it's like, well, I mean, okay.
Yeah.
Yeah.
That's it. And so exactly, if there's no symptoms and there's no clinical exam, well then there's no diagnosis that's gonna come up. And I'm usually a big proponent when it comes to, whether it's vulvar lichen sclerosus or penile lichen sclerosus, you need that clinical exam. Um,
Absolutely.
a doctor cannot diagnose you with lichen sclerosus over the phone. I will maintain that until the day I die.
Yeah. And I have a hard time. I have a hard time even of doing like virtual visits for this kind of a thing, like when you're looking at static images and diagnosing
Mhm.
lichen sclerosus. I mean, if it's kind of like slam dunk, okay, maybe, but I do think an in-person exam with a full skin check is pretty important.
Yeah, agreed. Yeah, 100%. Let's chat about skin cancer risk. So we know
Yeah.
with vulvar lichen sclerosus, there's a slightly elevated risk of developing into vulvar cancer.
Yeah.
Percentages vary, but I think the window is kind of a 2 to 6% chance. Is there
Yeah.
something similar risk-wise with cancer when you have penile lichen sclerosus? Do we know anything on that?
Yeah. So again, I think that it's funny because I feel like vulvar LS is pretty under researched, but penile LS is incredibly under
Yes.
researched.
Yes.
But there are a few studies out there that have documented an increased risk of developing squamous cell carcinoma in the setting of penile lichen sclerosus. And the risk that is out there, the rate of malignancy is a wide range again, anywhere from 2.3 to 8.4% is the stat that I saw. But
Okay.
again, there's one of these like really interesting reverse studies. So, like the first case where you're looking at circumcision specimens and how many of them have LS, and it's like a really large amount. If you look at patients who have penile squamous cell carcinoma, so patients who are coming in and they have a lesion
Oh.
and the penis is biopsied and they are diagnosed with a squame, if you look at the pathology of that, one study found that 28 or it must have been a more than one study because I have a range here, but there's
Mhm.
been between 28 and 44% of those specimens have LS, which
Interesting.
again is like almost half of patients who are coming in with a diagnosis of penile LS. When you look at their excision, they have when they're coming in for a diagnosis of penile squame, when you look at their excision, they have LS, which is crazy too.
Mhm.
So
Yeah,
one of
I
the
think this just speaks to the gross lack of research in this
yeah,
area for sure.
yeah, and I think one of the papers I was looking at was thinking about whether um, penile LS is actually just a pre-malignant condition in,
Mm,
and I mean, again, we don't really have the data to kind of refute um, or or confirm that, but I think that's one of the thoughts out there too, because you have so many of these patients who have penile squames who also have LS.
yeah.
So yeah,
Yeah.
there is an increased risk, and that's why we sort of treat and monitor these patients similar to um, the vulvar LS patients.
Mhm. And then in terms of diagnosis, okay, let's start with what kind of a doctor would we even go see? So many of the people with penile lichen sclerosus tell me they didn't even know where to start. Because a lot of us with vulvas, we kind of go see the gynecologist. It's so embedded into our cultures, but
Yeah.
not so much the other way around. So what kind of doctors would diagnose
Yeah,
this?
so I think the main doctors that are looking at this are going to be urologists who work with penises all the time,
Mhm.
um, and dermatologists who work with skin all the time. And then I guess thirdly would be a general practitioner of some sort who you're coming to complaining for any general issues. I also think maybe, and we don't really have this so well developed, I think, in the US, but some of the papers I've looked at, they'll get referrals from like sexual wellness clinics, and I feel like that's like a UK thing, or maybe
Okay,
it's like
yeah.
an infectious disease clinic of some sort where you think you maybe have some kind of
Oh.
infectious disease, so you'll go there and then they'll be like, oh, well, no, actually, I think you have LS. You should see like a dermatologist or a urologist.
I could see that. Yeah. I mean,
Yeah,
a lot of times when we have genitals and we say there's itch or pain, the first thought,
first thought.
of many healthcare providers is, okay, we've got an STI, sexually
Right.
transmitted infection. Let's either send them, to a testing clinic or let's send them, to your point, to infectious disease.
Yeah.
But yeah, when that all comes up negative, then we have to start to think, oh, okay, what else could be going on? So that is true that I think maybe there are some people that their first path is that infectious disease.
Yeah. And I mean, in dermatology, we do a lot of infectious disease because you get a lot of skin infections.
Right.
So I know here at the University of Utah, we have a rapid access dermatology or same day dermatology where we do a lot of genital rashes in that clinic as people will wake up and be like, wait a minute, why is my penis itchy today? And it looks a little red. And like,
Yeah.
it's a great clinic because you can get in pretty quickly. But so we see a lot of acute genital rashes, and historically, dermatology used to be the history of dermatology is kind of crazy because it used to be syphilology. So we did a lot of syphilis, and syphilis kind of
Mm.
is an infectious disease of the genitals, and alongside that, you have a lot of infectious diseases, and not so much this day and age. Where there's no longer syphilology departments. Maybe there are in Europe. They do a lot
Mm.
more venereal disease there, but yeah. So I think those three are probably the main go-to areas.
Got it. And
So
then
that's why, yeah, I was like, didn't you? Doesn't a urologist want to talk about this with you, Jacqueline?
yeah, I know it's wild that we couldn't that we've had such a hard time finding a healthcare provider who is willing to come on and chat about this. If there's any urologists watching that want to, add more
Chime in.
content, there's a huge lack, right?
Totally.
Research wise, representation wise, support groups, like all of this, there's a huge lack. So if anyone does want to contribute in any way, I think it'd be great to have more content and more awareness built around this. But yeah, so urologist, GP, and dermatologists are going to be kind of the main points of contact there. And then in terms of diagnosing, so with vulvar lichen sclerosus, we can do a clinical diagnosis
Yeah.
or a biopsy diagnosis. Is there something similar with penile lichen sclerosus? Would you also biopsy? How does that work?
Yeah, I think there is a very similar kind of differential as well that goes through your mind when someone is
Yeah.
presenting with penile or vulvar depigmentation or redness. And a lot of the time, if there is that kind of sclerotic atrophic look and the whiteness, then you do think of LS, and you can diagnose it on clinical exam. A biopsy sometimes can be helpful, and if there's any kind of hesitation as to whether that is the correct diagnosis, then a biopsy can be very helpful. I also think because there is potential, because balanitis or inflammation of the penis is very common and it can be caused by infectious etiologies. I think kind of ruling out infection is important in these cases if you're not doing
Right.
a biopsy. And then if there are other considerations on that differential, like lichen planus, for example, which can affect the penis and can look similar to lichen sclerosus, then checking inside the mouth is really important to make sure there aren't any lesions of LP there, because the LP really likes to involve the mouth. And then looking at the rest of the skin to see if there aren't any other rashes that might be related to the genital rash. The biopsy is always gold standard, but it's not absolutely critical. Sometimes it's nice to have if you're initiating someone on lifelong treatment, which is
Yeah.
usually what penile lichen sclerosus requires. So having that and saying, well, now we're going to have you do maintenance for pretty much the majority of your life, having that biopsy is pretty good incentive for that.
Mm-hmm. And then in terms of differentials, so we mentioned lichen planus and balanitis. Are there other differentials that kind of may pop up in these scenarios? And what would those be?
Yeah, so the other things that sometimes present on the penis like that is something called Zun's balanitis,
Yeah.
which is like an inflammatory disease of the penile skin as well. And then dermatitis or eczema of their penis is always on the differential when there's hypopigmentation
Okay.
or itch. Um, Sometimes psoriasis can affect the genital skin, and it can look a little bit like lichen sclerosus. So you also want to think about that when you're evaluating a rash in the genitals. So those are sort of the main ones out there.
So there's still quite a few differentials to work
Yeah,
through then.
there's
It's
still some
not
stuff to
always
piece through.
straightforward.
And my take on biopsies, I oscillate between doing like a ton of biopsies and not doing a lot of biopsies
Mm-hmm.
in my own clinic. So I just feel like really it does depend on the clinical situation about whether or not it is necessary to make a definitive diagnosis.
Gotcha. In terms of a biopsy, what does that look like? So we know for lichen sclerosus, uh, sometimes there is a numbing cream applied first, and then an injection of anesthetic, and then they will do a punch biopsy.
Mhm.
So with the penis, is there some numbing cream before the injection? Is it also a punch biopsy, or would it be a shave
Yeah, I mean,
biopsy? How does that look?
it'll depend as well on the areas of the penis that are involved.
Okay.
Um, so the anatomy, it will depend on where it is. So if it's like foreskin, I feel like that's a pretty easy biopsy to do, because you can just snip a small portion of foreskin and send that off.
Okay.
If it's on the glands of the penis, I mean, you can do a punch. It would probably be a really tiny punch, a shallow punch. I think a shave is probably better and heals better, because most of the time the disease is not going to be in the deep um, dermis, so you don't have to like hub a punch if you're doing a punch.
Okay.
You really just have to get a superficial piece so that you can get a look at the epidermis and a little bit of the superficial dermis, so you can appreciate that homogenization of the collagen fibers in that dermis, as well as the lichenoid inflammation. Um,
Okay.
so in my own experiences, I have done both a punch and a shave. Genital skin heals really well. There's a very big blood supply, so typically the healing is pretty quick. The numbing cream situation really will depend on where you're going.
Okay.
Most dermatology places do not use numbing cream; they'll just go straight and inject the lidocaine directly into the lesion. The numbing cream is really like an added bonus if you're like in a specialized clinic, I think, at least from my own experience.
Yeah, that's the sense I get to, at least in the VLS community space. That's typically what I hear, is that if the numbing cream is offered, it's typically in these specialized clinics
Yeah,
versus like a hospital or a kind of public clinic
right.
type
Yeah.
situation. Are there any differences between how LS can present on the penis between circumcised and uncircumcised individuals?
Yeah, that is such a fantastic question. I feel like we literally know nothing about this. So,
Mhm.
one of the papers that I looked at argued that penile LS never occurs in a penis that was circumcised at birth.
Right. Okay.
So, and I'm like, well, okay, I think back to the cases I've seen like in real life, and I've only ever seen lichen sclerosus in an uncircumcised penis. So
Okay.
even this paper that looked at people who were biopsied in infancy, they were biopsied because they already had LS, or they were circumcised
Right.
because they already had LS. So patients who were circumcised in infancy were circumcised because they already had LS and they didn't have a
Mm,
circumcision at birth. So there was
right.
nobody in this population who had not, who had been circumcised who had LS. And one study had like one patient out of like 52 who was circumcised who had LS, and it wasn't clear about that person's clinical
Yeah.
history. So obviously, if one of the main areas of involvement is the actual foreskin and that foreskin is not present, then I, I would imagine there's involvement of the glands of the penis and probably more involvement of the meatus. And in patients who had a history of LS, then were circumcised, and then had recurrent LS, that presentation would predominantly be in the penile glands. Very rarely do you see involvement of the penile shaft, the testicles, or the perianal skin. That is
Okay.
exceedingly rare. I didn't find any reports of that in the literature, unlike vulvar LS, where you kind of get that figure eight distribution
Yeah.
and it goes down the perineum and around the bum hole, and like all the areas
Hmm.
there are involved.
Okay.
So yeah, I mean, I think that's definitely an area of further study, and we have so little information on that.
Yeah. Yeah. We really do. Okay. But that's still very insightful. Thank you. In
Yeah.
terms of treatment, what's our kind of first line go to here?
So first line typically will be high potency topical steroids, and it's going to be very similar to vulvar LS, where you're applying 1 or 2 times daily for this, like 3 month period, um, and then following up to see that there's resolution of the signs and symptoms of disease. A lot of the time, this topical steroid is used as a way to avoid surgery, and in most cases, treatment surgically is circumcision. So by removing that foreskin, you can treat the LS. So in patients who treat with the data out there, in patients who treat with topical steroids, you probably get about 50 to 60% of those patients resolve with high potency topical steroids. And
Okay.
then patients who are treated with circumcision, uh, the stat out there was more than 75% are cured of LS and they no longer have the disease. So those are the main two options. And again, there is the thought that you have maintenance afterwards, especially if you don't go the surgical route. And
Hmm.
again, we don't have like amazing trials or studies that have said, okay, the ideal maintenance regimen is doing this 2 times a week. So a lot of that is derived from the VLS work and from anecdotal experience of providers where you're doing that maintenance,
Hmm.
2 times a week with that high potency topical steroid.
Yeah, I remember when I kind of first came into this space and I was reading a lot like, oh, if you have lichen sclerosus on the penis, just get circumcised and then you're cured. But even in instances where circumcision is opted for, that's not a guarantee
It's not a
cure. Like,
guarantee.
yeah,
Yeah,
like the percentages are high in terms of symptom resolution and kind of
yeah,
clinical signs resolution, but it's not 100% of cases
yeah.
where we get that outcome. So,
Yeah, according to and in my training as a dermatologist, that's kind of like the thing that we're taught as well. Like circumcision is curative,
mhm,
but it's not 100% curative. There may be
right.
some residual symptoms of disease after circumcision.
Yeah, and of course that wouldn't work if you're already circumcised. So if you're already circumcised and have lichen sclerosus, then that's not an
Exactly.
option.
Yeah.
So you're going to go the topical corticosteroid route. We know that for vulvar lichen sclerosus, second line treatment often involves topical calcineurin inhibitors. Would those ever be used in a case of penile lichen sclerosus, or would you go for a different topical in that case?
Yeah, so tacrolimus is considered second line in the treatment of penile lichen sclerosis, very similar to what it is in vulvar lichen sclerosis. And there was, so this is second line, meaning these are patients who have failed high potency topical steroids. It
Mhm.
can also be considered as an adjunctive topical to topical steroids if you're kind of getting
Okay.
some resolution, but not quite there. There was one study that showed patients who were treated with just tacrolimus actually in the end have it were required more procedures and had more side effects compared to patients who were using steroids. So I feel like it is
Okay.
inferior to steroids and should not be used first line. And then, I mean, I personally don't like tacrolimus. Don't tell anybody, but um, and I don't. Not a lot of my patients like tacrolimus either, but I do give it the old college try when
Mhm.
potency steroids are not working. But I think the reality is, and some of the papers I looked at always bring up this like potential for carcinogenesis of some sort because there isn't a link with the
Yeah.
lymphoma. And then you're like, well, I'm already treating a disease that predisposes to developing squamous cell
Mhm.
carcinoma. So am I somehow synergizing that by using tacro? I
Right.
mean, there's nothing that supports that theoretical link in the literature, but
Of
that is
course.
one of the things that kind of like has popped up in my review of the use of tacrolimus in penile LS.
Okay, that makes sense. And then, are there any emerging therapies, treatments that are out there for penile lichen sclerosis that may not be, kind of FDA approved, but could
Yeah.
be potentially prescribed off label?
Yeah. So there's a lot of buzz right now in the use of topical JAK inhibitors in vulvar
Mhm.
LS. And I think there's definitely potential for that in the treatment of penile LS. I did not see any actual papers or case series looking at that specifically, but given that there are a number of trials looking at that in vulvar LS, I think there is potential for that. And there are a number of studies that have looked at whether things like CO2 laser therapy and
Mm,
platelet rich plasma injections can help with penile LS. And there's some kind of like emerging soft data that maybe that does help. And we have similar body of literature in the vulvar lichen sclerosus research
right.
arena. So I do think there is potential for that. But again, those are all kind of very early and not definitive right now.
That makes sense. Okay, so let's go back to the high potency topical
Yeah.
corticosteroids. Is it similar to vulvar lichen sclerosis in that we're applying more frequently in the beginning of, the kind of diagnosis and then tapering down to something maintenance? Is there like what does dosing typically look like? And I know that's going to vary per individual,
Yeah,
but
so it is very similar where you're doing more consistent daily application at the time of original application and then transitioning to a maintenance. Um, so usually I'll do once daily or twice daily, depending on severity of signs and symptoms. And I'll try to do that for 3 months and then transition to twice weekly or frequency that kind of helps manage symptoms. Um, there are a lot of kind of adjunctive things that I recommend as well, which is very similar to the vulvar LS situation. And primarily that's the kind of use of emollient and barrier creams to protect the
okay.
skin of the penis when you're not using the topical steroid. And that can definitely decrease symptoms and flares. Um, One of the things that is fascinating about penile LS and kind of does also or recently has been emerging, or there's a lot of discussion about it, is the role of urine in the pathogenesis
Mm,
of penile lichen sclerosus. And there were a number of papers that posit that chronic intermittent occlusive exposure to urine is a primary cause of penile lichen sclerosus. So when you have the foreskin there, after urination, a small amount of
mhm,
urine remains trapped in the meatus and then potentially dribbles down into the sort of foreskin and is trapped there. And then that
mhm,
intermittent chronic exposure over time causes this inflammatory response. And is it that there's just a cohort of patients who are genetically predisposed to developing that anyway? And then you add that kind of irritant
right.
dermatitis or that, or is it something in the urine that's causing it? And this one paper was really fascinating because it was kind of looking at the distribution of LS and how it's kind of more posteriorly so that it's only where the urine would kind of fall like with gravity and
Mhm,
it's not really often seen on the other side of the penis. So, this paper was recommending that you make sure you dry the penis thoroughly after urination and kind of shake out any urine that might be caught in the meatus so that there's no dribbling afterwards, which could
right.
then also cause flaring if you're one of these patients who hasn't had a circumcision. And then
Mhm,
using some kind of barrier cream onto that foreskin and the penis after urination and between so that you're protecting it also from any potential irritation. And there's like, there's some data as well that has shown a potential link of urinary incontinence and vulvar LS. So I can see how
Mhm.
that kind of might potentially play a role. And there's also a number of case reports that have found lichen sclerosus in patients who have urostomy tubes. So they have like urine that's coming out of their belly. And I actually have one of these patients
Mhm.
who has a urostomy tube, and they have lichen sclerosus around that tube. And there's constant kind of like urine
Wow.
dribbling out there. And they just have LS in that area. So, I mean, I think
Okay.
there's a lot of kind of more room for research here,
Yeah, for sure.
and what the role of urine might play in LS pathogenesis. But the penile literature, some portion of it seems to think that that is a main driving factor, and there's probably other kind of components like an autoimmune
Yeah.
predisposition, a genetic predisposition. So it's not like one thing; it's like multifactorial.
Yeah. Yeah. And I think the same is true of vulvar lichen sclerosus as well. It's
Absolutely,
unlikely that like urine is the one and only thing, but I mean, like the impact or the connection between urine and vulvar lichen sclerosus, I know is something that's been studied by Dr. Lisa Kirby in the UK, and also
yeah.
looking at incontinence and how that, so again, I too think it's multifactorial, but definitely something to consider and potentially counsel
Yeah, and then
patients
the
on.
other interesting thing that this one paper talked about, and I mean I hadn't thought about this, but like again that distribution of the LS in females, and you can have kind of urine dribbling all over like the perineum and
Right.
the bum, while if you have a penis, you don't really get that dribbling, and so you never
Interesting.
see like perineal or perianal LS involvement in
Right.
people with penises. So it was just I'm
Yeah.
not saying that there's a causation, but it was just an interesting sort of like, oh,
Right. I mean,
anatomical consideration.
yeah. I
But yeah,
mean,
I
we
think
obviously can't prove causation, but yeah, I agree. And that's
yeah,
definitely interesting and gives us things to think about for sure.
yeah.
Yeah. In terms of applying the topical corticosteroids, are you applying all over the penis, or are you kind of applying only where there's symptoms or signs, just the glands, just the
Yeah,
meatus? How
just
does that
I
work?
usually just recommend the glands and the foreskin.
Okay,
So not like the penile shaft or like the
right.
scrotum or anywhere around there. Really, just the areas that are predisposed to developing that LS.
Okay, perfect. Let's pivot over to sexual function and intimacy for a second. So we kind of alluded to it in the beginning, specifically when we were talking about phimosis,
Yeah.
and the ways in which phimosis can lead to pain. Could you maybe just elaborate a little bit more on how penile lichen sclerosus can affect sexual function and intimacy?
Yeah, so there's really a dearth of information when it comes to sexual function in patients who have penile LS, and we have a lot more robust data in the vulvar literature, and really that's not even
Mhm.
incredibly robust either. So that's kind of
Right.
speaking volumes. There was one paper that had looked at sexual function in people with penile lichen sclerosus, and it found that 82% of these patients who presented with this had some degree of sexual dysfunction,
Okay.
and not all of that was related to the LS itself. So I think a smaller, like maybe around 70%, thought that the LS was contributing to their sexual dysfunction. And a
Mhm.
lot of this was pain with, touching the penis,
Yeah.
penetrative intercourse, any kind of thing where there's that manipulation. And I think the reality is because there's so much inflammation in the penis when there is lichen sclerosus, that in of itself is causing pain.
Mhm.
So that's one potential way that happens. And I think if there is scarring and phimosis, then again, there's functional issues that can impair sexual abilities. Um, so I think treating the disease is really the best first line approach to decreasing sexual dysfunction, because again, eliminating that some of that inflammation can help with that discomfort.
Mhm.
And then um, I think ensuring that patients are using kind of adequate lubrication and kind of protecting the skin whenever they're engaging in any kind of sexual activity is also important, and kind of
Yeah.
helps in decreasing that sexual dysfunction.
Mhm. I think lichen sclerosis, just in general, right? If we think about it, it's a disease that affects the skin, but at the same time, it is so multifaceted. And if we think about it, sexual medicine doctors can come in and help with these things. Sex therapists can come and help with the kind of, if we think about it through that biopsychosocial lens, sexual function is more than just how we physically function. It's also, mental and up here. And I think this is just another space where, sex therapists and other type of healthcare providers can kind of work together to help manage the sexual function piece, because, it can be incredibly distressing when
Yeah, and
it impacts
I think also if the penis looks different, that
that.
can
Yeah.
play, a huge impact on kind of
Oh, yeah.
self-image and self-esteem. So, I mean, I think that plays an important role to it. As doctors, we kind of suck at sexual health. I mean, this is the reality.
Mm-hmm.
And it's not a very robust portion of our training.
Right.
And I think we don't have a lot of integrated things within the traditional kind of allopathic healthcare system where we're addressing this multidimensional sexual function in patients. So like sex therapists and things, I mean, does insurance even pay for this kind of a thing? Like these
Mm,
are patients are going out there and having to do a lot of legwork on their own because we don't have a lot of these things incorporated into the traditional healthcare system. That's kind of the sad reality
yeah.
of medicine in America these days. So I think bringing it up with the patient is super important, and then kind of working together to figure out a plan
Mm-hmm.
um, that will be reasonable given the constraints of what I personally have to offer.
Yeah.
Yeah,
Yeah, of course. Of course. I mean, one doctor can't play all those roles. No one can be sexual medicine doctor plus dermatologist plus,
I know.
gynecologist
Yeah,
plus
yeah,
urologist plus, sex therapist plus, and then, because our mental health is also a part of that.
totally.
So for some people lichen sclerosis, it may not be so much a sex therapist that's needed, but just, a regular therapist, or even something I think we overlook too sometimes is like pain counselors. When chronic pain is a big part of penile or vulvar lichen sclerosis,
Absolutely.
pain specialists can actually, or pain counselors, sorry, can be a great resource in helping to address that mental health piece of it all. And it's something that I even forget to mention sometimes, even though because I told my GP when she diagnosed me, I broke down it because this was probably like my fourth chronic condition that I was diagnosed with. And I was mid PhD at the time. So very, very stressed.
Yeah.
And I was crying and I said, I can't do this. I need help. And when I said that, I said, I don't need help as in medicine. I mean, yes, I'll take the medicine and that's important, but I
Yeah.
need help for up here because I can't do this anymore. And in addition to talking me through the different therapeutic modalities out there, she referred me to a pain clinic. And I was actually enrolled, and I am in Canada, so this is covered. So I didn't
Right.
pay for this, but it was a year-long program. And we went through, I think, initially 6 weeks of pain education. And then we were in these programs that was led by a psychotherapist. It involved like CBT, DBT, meditation,
Yeah. I love
so,
that.
so,
Yeah.
so much. Yeah, it was incredibly holistic, very robust. And
Yeah.
within this place, you could also, I mean, like they even, because I had trigeminal neuralgia, I mean, they even offered like nerve blocks and stuff like this. So they do physiological stuff as well, but
Yeah.
they also have that mental health piece. So I think that, if there's a chronic pain component to the penile LS, that even thinking outside the box sometimes, yes,
Yeah.
a therapist, yes, a counselor, yes, a support group, but maybe even, bringing up these pain clinics and pain counselors to kind of help through that.
Yeah. And I think you're absolutely right. I mean, pain can be a big part of this.
Mm-hmm.
And I haven't personally had a patient who has had kind of long-standing penile pain in the setting of LS, but there are, a couple of papers out there that have sort of recommended, like a topical gabapentin or some kind of topical
Right.
amitriptyline potentially as a medical thing. But I think you're
Mm-hmm.
absolutely right. And pain clinic usually is like um, fairly accessible. So I do think that is a legit option if that is one of the kind of sequela of the LS.
Mm-hmm.
Um, and then, I've sent a couple of patients to pain clinic here at the U, and that can be helpful in some settings.
Yeah, for sure. So I think it's just, as with vulvar lichen sclerosis, cases are so unique. And it's really about thinking through like what are the needs, what are the pain points, and how can we work together to get you to where you need to be. Um, so as we're kind of like rounding this out, wrapping things up,
Mhm.
what do you think are some, and I think I know the answer and it's everything. What do you think are some of the biggest gaps in research on penile lichen sclerosis? And you
Yeah,
can
I mean,
say everything.
yeah, I know. It's kind of like, so the things we talked about. So, what are the ideal treatment protocols? Is there a difference between treating like vulvar LS and penile LS?
Mhm.
What is the impact of LS on sexual function in males? Like,
Yeah.
we have very little understanding on that. Um, what is the risk? What is the risk of cancer development in patients who kind of are uncircumcised and have LS? And then the pathogenesis again, kind of,
Yeah.
but I mean that's kind of similar for vulvar LS. Like, what is the
Hmm.
pathogenesis? I have no idea.
Right. Right. Yeah.
Yeah,
So basically a lot of gaps. And this will
yeah,
become quickly apparent if you do a quick search in PubMed or Google Scholar, well, where you'll find an abysmal amount of
yeah.
research done on penile lichen sclerosis. So definitely something that I hope to see improve. Um, what advice would you have to other dermatologists or urologists that are kind of new to treating penile lichen sclerosis?
Yeah, I mean, I feel like for dermatologists, we definitely get this training in residency, and
Mhm.
we probably see a lot more vulvar LS. But I think as far as we know, transferring that knowledge to penile LS is fairly okay to do, and kind of using that skill set to address the situation is appropriate.
Mhm.
Um, and I think with penile LS, just and it's the same with vulvar LS. I feel like it's really important to form a relationship with the patient that you're treating with LS, because it can be such a all-encompassing disease. So
Mhm. Yeah.
making sure you have the ability and the time to kind of really establish this therapeutic relationship with these patients, I think is very important. Um, and then urologists, I think it goes the same way. I think being not afraid to ask for help is also very important in these situations. So if you have a colleague who
Right.
treats more penile LS, like you can text them, you can call them, and get advice on how to approach the issue, and then working with your colleague. So if you're a dermatologist who has a patient who has your some kind of phimosis or scarring, sending that referral early so that you can get a set of second eyes on the situation and see if they have anything to offer, as well as vice versa. So I think of kind of like dermatologists and urologists. Like, dermatologists are medical people. Like, yeah, we do a lot of procedures, but we're primarily
Mhm.
medicine doctors, while urologists are
Right.
primary surgeons. So they're going to be more kind of surgically minded, but keeping in mind that there are other effective treatments for lichen sclerosis of the penis that are not surgical. And a lot
Mhm.
of uncircumcised people do have a hard time wrapping their mind around getting circumcised. So it's not like an easy decision, right? Especially if you're
Yeah.
not a child. So that might not be a feasible option. So
True.
kind of chatting with other dermatologists who might have more experience with the medical treatment, and kind of um, keeping that conversation alive within the two subspecialties. And I think it goes the same for GPs. Like, I think it's totally fine for a GP to treat lichen sclerosis of the penis if they're comfortable treating that disease, but then knowing when they need to
Mm.
phone a friend for help when
Yeah.
things aren't responding.
Yeah. I think that's excellent advice. Thank you so much. This has been incredibly eye-opening for me. I definitely learned a lot. If anyone listening has penile lichen sclerosis and wants to maybe share their story in order to help kind of raise awareness, please reach out to us. We'd love to kind of feature you. And if you are a urologist, dermatologist, anybody working in the healthcare space that wants to share their research, we'd also love to center that. Before we close out, is there anything that you wanted to say on this topic but didn't get the opportunity to?
Um, yeah, I want to put a plug in for gentle penile skincare. I mean, this is kind of like the backbone of any skin disease. Is you want to make sure you're treating the penis gently, the penis skin gently. So one of the
Mm.
first line approaches, in addition to like topical steroids, is using a gentle cleanser for the penis, avoiding irritating fragrances, avoiding wipes, all that kind of stuff, and using a moisturizer. I think the importance of very simple changes to taking care of the skin can make a world of difference if you are someone who has penile lichen sclerosus. Gentle penile
Fantastic.
skincare. That's my new gentle
I
penile
love the
skin.
extra plug.
Yeah.
I'll try and create some kind of graphic for that. If folks want to follow you on social media, where can they find you?
I am on Instagram, Dr.Cocks, and Dr. Kylie Moss, who's a gynecologist out in DC. And I also have a podcast where we talk mostly about vulvas. Actually, we haven't talked about any penises, but it is Vulva Talk. And you can listen to our podcast on Spotify or Apple Podcasts.
Amazing. Well, thank you so much, Dr. Cocks. It's been a pleasure. Thank you for being the first to kind of step up and have this conversation. We are so grateful.
Like sweating.
And thank you to everyone listening.